We often talk about elective management of the neck based on the incidence of nodal or the risk of nodal metastasis in the clinically negative neck. My question to the panelists is, how do you assess this risk? We throw a number, 15% or more, we will do elective treatment, or 20% or more risk, we will do elective radiation, or 25% risk and we will do sentinel node mapping. How do you assess the risk of occult metastasis in the negative neck? And I'll start from the farther end, Professor Werner.
I think it's very difficult to assess the risk. And of course, these percentage numbers are sometimes from a time far away. They didn't have these very good examination instruments, devices. So I think it is very difficult. But I think in the future we should include probably some prognostic markers. I don't know, but I think this is one way to bring up a risk profile, and then to check this risk profile with different markers or different questions to indicate a selective neck dissection. But today, I don't have such a well-working risk profile.
Jeff?
I usually rely on the classic works by your group, Lindenberg and Byers, looking at site-specific areas within the upper digestive tract and the incidence seen both in N0 and M-positive necks. That's really what I still rely on. But it also depends on the site of treatment and treatment selection, and it becomes not an issue in many of the sites that we're not treating surgically, which sort of leaves the oral cavity as the major site. And then I sort of rely on the work done by your colleagues, Dr. Spiro, and depth of invasion or thickness of tumors, particularly for tongue and floor mouth tumors, to make a decision about electively treating the neck.
What is your threshold? At what risk would you want to investigate the neck or treat the neck?
In terms of depth of invasion?
Depth of invasion, or at what risk level? Depth of invasion will tell you that there is a 15% risk, for example, of finding nodal metastasis. Since you quoted Spiro's paper, let me give you the numbers on Spiro's paper. Ron Spiro in 1987 studied from our service floor of mouth and tongue carcinomas and its risk of nodal metastasis and its impact on survival based on thickness of the tumor. If the tumors were less than 2 millimeters thick, the risk of nodal metastasis was less than 15%. Between 2 and 9 millimeters, the risk was 26%. This is a retrospective analysis. And more than 9 millimeters, the incidence was 44% of micrometastasis. So when should we be concerned? If the risk is 10%, 20%, 40%?
In oral cavity cancer, probably, it's a high risk of occult nodal metastasis, and that's where I'm generally using this information about elective neck dissection. So all but the very thinnest lesions, probably less than 2 millimeters, and I'll often take a patient to the operating room that I can't convince to have an elective neck dissection and tell them that we'll do a frozen section after excision of the primary, and if it's more than a couple millimeters depth of invasion, I want to dissect your neck.
Okay, so generally it's a qualitative answer that if you feel the risk is significant, you would address the neck. Rene?
Yes, I would agree. And whether it be 15 or 20, I can think of only one publication in the literature that addressed this by means of decision analysis, and it's also from Memorial, I think, by Weiss et al., and they came to 20%. I would agree with Jochen entirely until we have not the availability of biologic prognostic factors. We have to rely on the literature, and in that respect, probably every tumor except for T1, T2 glottic, T1 supraglottic, or T1 oral cavity will probably qualify for elective treatment of the neck. and as I told you earlier, we have addressed this issue a little different and to tailor the treatment of the neck a little bit more to the actual involvement of the neck, yes or no, by means of ultrasound. But if you have not that availability or the patient lives someplace else, I think you need to dissect the neck in every patient with a priori chance of over 15 or 20%.
Professor Ambrosch?
We very much rely in sight, T category and depth of invasion, and since we treat the primary sites surgically and do most often staged neck dissections, we know the depth of invasion when we make the decision on the neck. And in the oral cavity cases, we found with our depth of invasion investigations a cutoff point of 4 millimeters, and with more than 4 millimeters, the risk of metastasizing increases fourfold. So this would be in our patients and with our kind of histopathology workup, where I would say 4 millimeters depth of invasion patient should have an elective neck dissection.
Okay, Dr. Hembeck?
Well, because of our excellent collaboration with Dr. Vogel here in Frankfurt since the last 3 years, we had the great opportunity to use these ultra-small particles in diagnosis of occult metastasis. And indeed, we used this system to decide whether to operate to make a neck dissection or not.
Okay, short answers because we've got many points to cover. How many of you use imaging to study occult metastasis? Yes or no? And if so, what imaging? Professor Werner?
I don't get the message.
Well, usually we'll use imaging to stage the primary and look for occult metastases at the same time. And again,
T2 and 0 tongue cancer, oral tongue.
I'll usually get a CT scan of the head and neck. I don't think it's absolutely necessary, but I typically do.
Okay, so you would use a CT with contrast. Rene?
Yes, T2 oral tongue ultrasound, fine needle aspiration.
Ultrasound, fine needle aspiration biopsy. Petra?
The same ultrasound. And
Ultrasound.
Mm-hmm.
Well,
Marcus?
We use an MRI.
MRI. Professor Werner?
Yeah, ultrasound, normally ultrasound.
T2 and 0, oral tongue. Any imaging study?
Ultrasound for the neck.
Ultrasound for the neck. It's interesting. The reason I ask this question is it's always a debate in the mind of people treating out in the community. What imaging to do? Is imaging necessary? How do you alter your management based on the findings of the imaging studies? So I'm going to now ask the questions to those who you responded. How do you use that information in planning your treatment? Let's start with this end. Marcus, you ordered an MRI. MRI shows a 1 centimeter questionable lymph node at level 2. Does that affect your decision regarding treating the neck or the extent of treatment of the neck?
Well, when you have, what was the measurement? I didn't catch it.
It's a palpable lesion. You can feel it.
Okay. So in this case, if the radiologist tells us this is, seems to be in metastasis, we're going to make a selective neck dissection.
So you do a comprehensive neck, all 5 levels?
No, adapted. A selective neck dissection, normally we would do it from 1 to 4.
How did the MRI finding change your approach? That's what I'm trying to ask. Because we oftentimes do studies which may not necessarily impact upon what you do with that information.
Well,
Professor Werner.
For example, T2 and 0 oral tongue. We would always do a neck dissection, a selective neck dissection. So I can discuss what is about the primary or special deep infiltration or so. But I think, and I think you agree or not, if you would treat such a patient with, of course, 3 millimeter infiltration depth, would you do a neck dissection?
If the lesion is palpably measurable, I don't do excision and frozen section. If my fingers tell me the lesion is thick, implying at least more than 2 millimeters, we would do an elective supraomohyoid neck dissection.
So I think all these discussions, shall we do this imaging or this imaging? I think a T2 because it's a staging procedure.
Exactly right.
And then we can go the next step to say there is no need for radiation therapy.
Okay,
and
fair
then
enough.
we can discuss there is one small lymph node, and I think this is very important. Shall we use radiotherapy in one small lymph node, no perinodal
We are
spread?
coming to that.
But this is
Yeah. So let's summarize what we have learned from the first point here. That in the clinically negative neck, the risk factors are the T stage of the primary tumor, the thickness of the primary tumor, the location of the primary tumor, whether it is anterior in the oral cavity or posterior in the oral cavity, and certain primary sites which have an inherently higher risk than others in the oral cavity. For example, tongue versus hard palate, floor of mouth versus buccal mucosa. So those are the factors you would use in choosing an elective, selective operation. Do you, coming to you, Jeff, in a second, do you plan your treatment based on the knowledge of patterns of metastasis? Or are there any exceptions to that pattern information, and if so, what are they? Jeffrey, go ahead.
Well, I just wanted to comment on, your point about not ordering an imaging test that's not going to change your management is well taken, but I try to avoid surprises like if you might pick up an occult contralateral metastasis that might help in your treatment planning, or a depth of invasion or extent of the tumor that you might not have perceived on your physical exam.
Point well made. The issue is we have sufficient information in the literature about the patterns of metastasis. Excellent studies by Bob Byers and colleagues from MD Anderson and from our group to show that the patterns of metastasis in the neck from mouth cancer are predictable, and that there is sequential progression of disease from the upper part of the neck to the lower part of the neck. Are there any exceptions to this? And if they are, what are they? Anybody? Instead of going through everybody, pick up. Rene?
Well, in the end-node neck, if in the anterior oral cavity, we would, as most people would probably do, dissect level 1, 2, 3. There's always the question of level 4, of course, and the famous skip metastasis in the situation where level 1, 2, 3 is negative on opening the neck, and even on taking a frozen section of level 3 node. But we would almost always do a level 1 to 3 in anterior oral cavity, and the same goes for larynx cancer, level 2 to 4 for elective.
So for oral cavity, you go up to include level 4 for oral cavity?
Oral cavity, we won't dissect level 4.
Okay, any specific primary sites where you make an exception?
I don't think that there's enough evidence to say like oral cavity has more chance for skip metastasis than floral mouth, for instance.
Okay. There is some retrospective information from MD Anderson. Jeffrey, you want to expand upon that for level 4 lateral tongue?
Yeah, I tend to dissect level 4, and I think the data are somewhat equivocal, but I find that extending the dissection down to that level really doesn't add much time or morbidity. And I have seen a skip metastasis on occasion, and I've seen patients who had supraomohyoid neck dissection return with that didn't have nodes that had a skip metastasis in level 4 and recurred there. And it's not a huge number of patients, but enough to say I'll just take the extra. I don't think it's real scientific data, but it's enough clinical anecdotal experience for myself to dissect level 4.
I think the rationale of bringing that point was that particularly for lateral tongue, oral cavity, middle third, there is a slightly increased risk of skip metastasis to level 4. The paper by Bob Byers shows a pretty high number, 15% if my memory serves me correct. But that was not in the absence of levels 2, 3 involvement. Isolated metastasis to level 4 do occur, but rarely, and that generally from lateral tongue in the middle third. So if the primary is in the lateral third of the lateral border of the middle third of the tongue, including level 4, would make a sense. I agree with you. It doesn't add much time or much exposure requirement, adds few more minutes, but sometimes can get you out of a potential trouble down the road. Professor Steiner.
Since over 25 years, we send always the lymph nodes from every level separately to the pathologist. Though we know exactly where are the so-called clinically occult micrometastases. During my last visit to MD Anderson, I was first discussing with the pathologist, it's really possible that you can describe exactly that this lymph node is in the level 4 or 3. And he said, no, I cannot do it. And then I was talking to Bias, and that you have to know that in Europe, we don't believe in this paper. There's no skip metastasis. This is, of course, you can remove the level 4. It's not a big issue. You can do it. We have discussed it 91 in Göttingen with Göpfert and many famous head and neck surgeons are from around the world. Exactly this problem, level 4 or not. But Bias told me it can be. That because they have not sent every level, they have sent a specimen. And it's very difficult for the pathologist to be oriented, is level 3 or level 4. So in my opinion, this is a misinterpretation.
Okay, point well made, but I think it also needs expansion. If I recall correct, your processing system of lymph nodes at Anderson right now is that you map the specimen on a mounted plate and indicate the levels to the pathologist when the specimen goes down. Is that correct?
That's correct, or we separate them and send them over. But I mean, I agree. At times you take the specimen out and, you know, it's a little bit arbitrary where you're making those cuts. You don't, I think if during the neck dissection you could, you know, look at those markers and cut off your specimen and send it, that'd probably be the best way to do it, but it sort of disrupts the flow of the operation. It's not how we typically do it, so we either mount it at the end or we cut it in levels at the end. But sometimes, you know, a millimeter here or a centimeter here or there where you make the cut might make a difference.
We, at Memorial, we use numerical tags, levels 1, 2, 3. But I would agree with you, you know, the distinction is minor. But clinically, it is a fact that patients do come sometimes after supraomohyoid neck dissection with recurrence at level 4. I have at least 3 patients I remember in my practice who have come back with level 4 recurrence from tongue carcinoma. So there is a small but finite evidence. Let's move on. I think I want to cover these topics. These are important. We talked about how we identify occult metastasis. We talked about imaging. We talked about elective dissection. How many of you routinely employ sentinel node mapping amongst the panelists?
Yep.
Outside of a clinical trial?
Yep.
In routine practice. Anybody from the audience, sentinel node mapping? Okay, so that means we need to talk about sentinel node mapping. Since nobody is using it. Okay, let's talk about it. If you were to do, and those of you who participate in the trials, do you do radioisotope imaging, blue dye, or both? I think the person who can probably answer is Professor Werner. You've done the collaborative study review.
Yeah, we did both methods and also a combined method of both of them. But I think technetium is very well. You can use this with a gamma probe and you have an exact diagnosis of these different lymph nodes. And what I forgot during my lecture was if you try to use the sentinel node, and we discussed this outside half an hour ago, if you use the sentinel node concept for melanomas in the skin, in the face, then of course we have the problem for the parotid lymph nodes. And I think this is also a different approach. These high number or relative high number of parotid lymph nodes. So if the dermatologists use this, and they treat a lot of the melanomas, of course, they have to be aware that there is a high amount of several parotid lymph nodes.
Okay. The reason I wanted to bring this up was the following, that if you are going to do sentinel node mapping, the accuracy of finding metastasis or finding the sentinel node, I should say, is increased by about 3 or 4% if you use the isotope imaging, a handheld probe, blue dye injection, and identification of the node by blue dye as well as the handheld probe will bring your accuracy to 97% in identifying the sentinel lymph node. But I think in as much as we are told, nobody in routine practice is using it except for the context of clinical trial. How far should we go to identify disease in the sentinel lymph node? Frozen section, paraffin section, immunohistochemistry, or PCR? Dr. Myers?
Well, I wanted to make a couple comments about sentinel node. I think the use of the blue dye can be a little bit trickier within the oral cavity than within the skin. Just technically, it's harder to do. And I think that the gamma probe is maybe more useful, but I think it is the learning curve is probably greater than for melanoma. I think it's technically quite challenging to do this. In the States, we have a clinical trial with the American College of Surgeons Oncology group of 161 patients. We've accrued about 157, so within the year, we should have some results on that. You know, I think versus doing it in the skin of the head and neck, which again is different than skin of the trunk and extremities, where it's a very small incision in an area without a lot of risky anatomy. I think it's complex, and I think when you treat a primary tumor of the oral cavity and already you're making an incision in the neck to get a sentinel node, the question is, are you going to come back and, you know, after a fairly major procedure and do the rest of the neck dissection? And that comes to this point about PCR molecular techniques. And my father in his lecture yesterday mentioned the paper by Bob Ferris and colleagues, where sort of in real time, within half an hour, you could get a PCR answer about cytokeratin expression within the lymph node. I think you really need something like that to make this technique applicable to the treatment of head and neck cancer.
So it's still work in progress, experimental, not clinically applicable. Fair, is that a fair summary?
Yeah, precisely.
Okay, let me go back to, can we go back to the 3 slides? One more. Thank you. We have gone on to do an elective dissection. We have to identify occult metastasis. We have done an appropriate regional dissection, be it levels 1, 2, 3 for mouth cancer or 2, 3, 4 for larynx, pharynx cancer. At what stage will you decide there is the need for adjuvant treatment? What is the extent of occult disease that would lead you to adjuvant postoperative radiation therapy? Is finding occult metastasis, which is all intranodal, surgery sufficient treatment, or do they need adjuvant treatment? Let me start with Professor Ambrose, and then we'll come to the other end.
In our evaluation of the neck dissections, in the PN1 cases without extranodal spread, we saw not a big difference with the later recurrence rates, whether the patients were irradiated or not. And the statisticians say there might be a tendency towards a better control, better regional control with postoperative adjuvant radiotherapy. But this is open to discussion. Maybe this would be a good issue for a randomized study whether it's actually necessary. In the PN2 cases, as in more 2 and more metastases, we strongly would recommend postoperative adjuvant radiotherapy in case we do not irradiate these patients. You will have 20% regional recurrences.
So single lymph node, intranodal metastasis, only surgery, no radiotherapy.
See,
Rene?
control, wait and see.
Yes, in general, I would agree. It might depend also a wee bit on the exact location of the node. If it were in level 3 and that was the last level you dissected, you might discuss whether or not you need adjuvant radiation therapy. But for a single intracapsular metastasis, I would also tend to not radiate.
So if I rephrase your statement, single intranodal metastasis in expected level, no adjuvant treatment. In unexpected location,
right,
you would consider adjuvant treatment because of the unusual pattern of metastasis. Fair enough?
Exactly.
Jeffrey?
I have a data slide I wanted to show.
Can we look at Dr. Meyer's slides?
It'd be my second slide. Here it is. So the number was higher. We had a total of 44 patients. 4 of 24 that did not receive radiotherapy recurred in the basin, and 0 of 17 that received radiation recurred.
Okay. Renee, you have some comment?
Yeah, I think that's quite astonishing because here you do a procedure to limit morbidity, and you would have not irradiated if you would have done a comprehensive neck dissection, most probably. And now you're going to add radiation therapy on top of your selective neck dissection. I think that's something to think of.
But isn't selective neck dissection a staging procedure?
Yeah, but then again, if you would have done a modified radical and you would have found one node within the capsule, you would probably not have irradiated.
Okay, let me ask a few people sitting in the audience, but I want short answers, otherwise we will not cover topics. Professor Rapidis first and the gentleman in blue shirt next.
The panel said if you find a single node with no extracapsular spread, if you had the node with an extracapsular spread, it wouldn't have to be an N0 neck. We're talking about small, in order to have, in most cases, in order to have an extracapsular spread, the lymph node would have been more than at least 1 centimeter, so the patient would have been classified N1. So we're talking about N0 necks. If you find, how often do we find more than 2 lymph nodes in an N0 neck? Very seldomly, because, you know, if you do a 3 or 4 levels and you dissect, again, we don't know how many lymph nodes a comprehensive or a selective neck dissection should contain. Is the pathologist who says, I found 15 lymph nodes or I found 57 lymph nodes. It depends on the neck dissection, of the technique, and how often can you have an extracapsular spread in a lymph node of non-detectable in other techniques. And again, the question of post-operative radiotherapy or not is not of if I have 1, I don't do it. If I have 2, I do it. Because, you know, it's, I think it's, you have to see the primary lesion, your, how well you have resected the tumor, the other parameters before saying I'm sending it to the radiotherapist or not.
Thank you. Sir, in the back, I'm going to ask 2 other gentlemen to comment on Kerry B. prepared for Mayo Clinic approach, and Pat, what do you do in England? Go ahead.
I think it is difficult to be sure to have removed all lymph nodes, especially in level 1. So in the confirmed, pathologically confirmed N0 neck, this is not so important as in the proven singular metastasis. Then one has to ask oneself the question, might there be a residual micrometastasis in the neck, in the area I dissected? I think in my hands I'm never sure not to leave lymph nodes in the submandibular groove or in the lobus coeli of the parotid gland.
Okay. Incidentally, the risk of extracapsular spread by size of lymph nodes has been quantified from the Amsterdam group. Even a 1 centimeter lymph node has a 24% risk of capsular rupture. Well-published data, and I think it's been duplicated by the Pittsburgh group also. Pat, Dr. Bradley, what do you do in England? Short answer, please.
2 nodes we radiate, 1 extracapsular node we radiate, and soft tissue extension we radiate.
Perfect. So multiple lymph nodes, capsular rupture, and soft tissue extension of disease. Fair enough?
Extracapsular disease, we always radiate. For a single node that's pathologically positive, we would not. We would consider doing a suprahemorrhoid and effective operation. And in actuality, even in cases of 2 nodes, sometimes if the pathologist calls and says they see little micromets within 2 nodes, we'll still not radiate those.
Okay. I think, the hour is getting late, but I'm going to ask each of the panelists to make one closing statement of their choice on any aspect of neck metastasis that they feel compelled to say. Let's start with Professor Werner. Yes, sir. Short question, please. Very short.
To Jeffrey, which primary, the statistic you have shown us?
This is all oral tongue cancer.
Oral. And how many levels you have dissected? In both groups the same?
It was 1 through 3 or 1 through 4.
Always the same?
Well,
or different?
there were, 8 or 12 surgeons over the years. Some did 1 through 3 and some did 1 through 4.
And the last question to Dr. Lehman. In Amsterdam for many years, Snow has performed always a modified radical neck dissection, even in N0 neck. Is this your concept too, or you changed? Did you change? Change. And for laryngeal cancer in MD Anderson, level 2 and 3 or more?
Yeah, in the rare cases that we treat surgically, primarily, usually 2, 3, and 4.
Okay. But nobody performs a 5-level dissection anymore in N0.
Correct.
That's right?
I think nobody, at least that I am aware of in the United States, dissects level 5 and then N0 neck for any primary site, unless you are dealing with skin or melanoma. Final statement, short from each of the panelists.
I don't have a statement. I'm very satisfied with this discussion because I have the hope now that we can have a consensus in some parts of Germany at least. So and this is my final statement.
Okay.
Well, I just wanted to add the last word on that. N1 no ECS, so that'll be my final statement. And it's actually 2 parts to the statement. Part A is that it's a small number, and we're going back now and looking at all our oral cavity patients, because I think it's data that's not conclusive, but it's data that's suggestive and concerning. And with that data in hand, I feel compelled to discuss it with patients when they come back and I have that exact pathology report. And I push them towards, I don't push them, but when they say, Doc, what would you do? I'd say I would probably take the radiation, because once they recur in the neck, it's after a neck dissection, it's difficult to salvage them.
Well, Jay, I hope in future we can tailor our management of the neck more to the patient and not so much to the literature and retrospective studies only. So biological or better imaging of the neck, I think, would be the future, and that we can spare the majority of patients in certain instances that do not need a neck dissection.
Okay, Professor Ambrosch?
I would say selective neck dissection is curative in the N0 neck, and we see this when we have a look on the recurrence rates of under 5%.
Okay, Marcus?
I would say that new diagnostic methods will guide us to the future.
The remarks made by our panelists tells you the diversity of the field, that there are many priorities in the management of the neck, that there are no definitive answers, and we need to do a lot of work. Thank you. I want to also express my appreciation to Professor Knecht and Professor Hembeck for inviting me to be a part of this program. I've enjoyed the program, learned a lot, and I hope you had an enjoyable session in the afternoon. Thank you.